Okay, hello. I'm going to give this talk in English. I'm afraid my French is terrible. Okay, well, this afternoon I'm going to be talking about non-tols or non-tolerances, rechecks and remakes. So this is when a patient gets some glasses, they don't like them for whatever reason, they return to the practice and they say, these are awful, please sort them out. So I'm going to discuss why they occur and how we should try and avoid them. The worldwide recheck rate for rechecks is just over 2%. So that might seem small, and it probably is, because there's a lot of people who do have problems with their glasses but don't come back to the practice. So there's a lot more people out there that are not happy with their glasses. Typically they will go and see another optometrist or optician. So 2.2% is probably the smallest it is. It's probably bigger than that. But even 2.2% means that in the UK, with 22.5 million eye exams per year and a 67% dispense rate, you've got over 1/3 rechecks a year. That's a lot of people who are unhappy with glasses. So we need to try and avoid that if we can. This is from a Daily Mail cartoon, having trouble getting used to your new specs. What they shows is how common this is and how the cartoonists expected people to understand this immediately. So this is common. This getting used to glasses and not being able to find the steps, that's a common occurrence. So is it important? Well, I think it is, yes. Why? Because there's a cost to you. The cost is, well, as an optometrist, you've got a recheck eye exam. You've got to examine their eyes again. You've got to refract them again. Most likely, you will have to reglaze the glasses, and that's free. So you providing those, the recheck, the reglaze spectacles for free. The lenses will have to be free. And also, you've got a tarnishing of your reputation. People will say, don't go to them, the glasses are awful. So you need to sort it out. We need to try and reduce it, but if they do return, we need to try and sort it out. What you shouldn't do is this. The optician said I was mistaken about things looking blurry through my new specs. They were perfect, and I would get used to them eventually. And again, why I included this to indicate how common it is that people will understand this because they've been told this. No, don't try and fob them off and say, oh, just go away, you'll get used to them. Listen to them properly, sort it out. If they need new glasses, sort them out with new glasses. Don't fob them off, don't tell them to go away. So why did it happen? In fact, most of them are not due to the patient. They are due to the optometrist, the clinician. And 60 to 83% are prescription errors. They are errors by the optometrist. So non-tolerance, because non-tolerance suggests it's the patient not tolerating what is correct. Well, it's not. It's not a non-tolerance. It's a misnomer. Most of them are errors by the optometrist. So we need to understand that and accept that. And most of them are found with presbyope. So it's with older patients who adapt less easily to new glasses. Older patients really don't like getting new glasses because they know they're going to have to adapt to them and they know it's going to be hard. So why? Why do we get errors occurring? Well, refraction results are variable. They are not fixed. Somebody isn't, you're a -2. No. If you examine somebody, an individual clinician will get within 0.25 of the result 80% of the time. But between clinicians, you can get up to 0.75 differences. So one clinician will say -2, another clinician will say -275. You will get that. That's the higher limits, because most are close, but it's variable. It's not exact. It is variable. And that could be clinician errors, but also unreliable patient responses. And patients do worry, again, older patients really worry about those responses. They don't like doing subjective refraction. They don't like saying, is it 1 or 2? Is it better with or without? They really don't like that. And the other thing to note, these two papers, Miller and Atchison, published in the optometry journals, Optometry and Vision Science, and OPO is Ophthalmic and Physiological Optics. What they did is they got glasses that were correct and then added small errors. 025, 050, 025 sphere, small SIL. And what they found is that small errors can cause symptoms. Only just 025. And you can get problems, the patient doesn't like the glasses, they've got symptoms. What we also need to be wary of as well is working distances. These are data of reading ads on here as a function of age. And as you can see, it is bilinear. So this bit is where the amplitude of accommodation is lost with age. As we lose accommodation, we need a greater reading ad. Accommodation, by objectively, is 0 here. Nobody has any accommodation over that point. What you might measure is depth of focus, but nobody has any accommodation above here. So what's this then? Why does it increase after the age of 60? It's because some patients will get cataract, they will get macular degeneration, they can't see as well, and so they do this. They need to bring their text closer so they can see, so it's magnified and they can see, and therefore their working distance is reduced, and therefore some of them need a higher ad. What that means is that getting the working distance correct is vital. So we need to be really clear about what do our patients do at near, what distance, and measure that distance so that the ad is correct. Because over 60, that's all it's based on. It's based on the working distances of whatever task they're doing. So just to go over why these things occur, because you think, well, you've got new glasses, the visual acuity should improve. Absolutely, if the refraction's correct. But there are other changes that we need to consider, and one is magnification. I like to add a little bit of Monet to, there is a relevance to this. The great thing about Monet is he painted the same thing over and over again throughout his life. So this is his Japanese bridge in his garden, and I'm going to pronounce this wrong, Giverny. It is? Merci. In Giverny, and this is when he was about 62, and he could see well. So there's his bridge, there's his water lilies in his pool. This is when he was 82. That's the Japanese bridge. He was legally blind at 82. He had no light perception in one eye. He had 660 in the other eye. Couldn't see. And he also had nuclear cataract, because notice the difference. Blue and green. Lots of blue, lots of green. Bit of green, but the blue's gone, and it's lots of red and yellow. The blue had all been absorbed by the nuclear cataract, so he had huge colour changes. He then had cataract surgery, and this is where it's relevant. And he got new glasses from Zeiss, plus 10. No implants to correct the correction in those days, with a minus 4 at 90, and that gave him 618. He hated them, as you can imagine. This is from his diaries. That's the other great thing about Monet. All his letters are collected by Wildenstein and published. And this is a letter to his doctor, Clemenceau. So there's Monet with his broad brim hat to reduce the glare. And there's his doctor. What he says is the distortion and exaggerated colours. He hated the blue once he'd had cataract surgery. that I see are quite terrifying. As for going out for a walk in these specs, it is out of the question for the moment. So his new specs, because of the magnification and because of the distortion, which is magnification in the two directions, he couldn't even go out for a walk in them. And we all understand that. We say, well, yeah, obviously, plus 10 minus 4, that would be horrible. So the question is, how much magnification change causes problems? And it's not that big. One of the things that we have with magnification that I should point out is the vestibulo-ocular reflex gain. So this is where, when you nod your head, the world doesn't go all over the place. Because as I move my head down, my eyes move up at the same speed. Now, when you get new glasses, that doesn't happen, because they have to relearn the speed that the eyes move up. So while they're adapting to that, and older people will take more time to adapt, the world appears to swim. You move your head, the world swims. So what changes with new glasses? Let's summarize. Visual acuity improves if the refraction is accurate. If you over plus, it leads to blur, so that's more of an issue. And remember that refraction at 6 meters is actually blurring the far, far distance by 0.17 diopters. So refracting at 6 meters isn't perfect. You've also got magnification changes, which affects the perceived size and distance away of objects, like steps and stairs. Vision is hugely important for knowing where steps and stairs are. And any change in magnification can disrupt that. It disrupts the vestibulo-ocular reflex and can make the world swim. And astigmatic changes causes walls, floors to slope and can cause dizziness. So what can we do about it? Well, when we are prescribing, we don't need to give what we found in the subjective refraction. It's not automatic that once you've refracted somebody, that's the number they should get. No. You've got to consider what they've been wearing, what the symptoms are, what your subjective refraction is, and then decide what you're going to prescribe. It needn't be the subjective refraction. And there are actually 3 American textbooks that are dedicated to this. Clinical Pearls in Refractive Care by Werner and Press. Refractive Management of Ametropia by Bruckmann, they're both optometrists. And The Fine Art of Prescribing Glasses Without Making a Fool of Yourself by Mulder and Rubin, who are American ophthalmologists. And what we've found is that these prescribing rules are used, but only by experienced optometrists. Youngsters, young optometrists, don't use them typically. What we think is you get a patient who comes in and says, I can't wear these, and then you learn what works. And then you see another patient, I can't wear these, you learn what works. And over the years, you see enough patients who are unhappy and enough what works that you change what you do. And you don't prescribe the subjective refraction. So an increase of 34% use of these prescribing rules, which I will go through, per 10 years of experience. So prescribing rules. As I said, at the recheck, clinician looks at the change in spectacles and tries to understand why is the symptoms. Refract again and give new glasses. The new glasses work and the patient is happy, and therefore the clinician develops an understanding of what refractive error changes lead to problems and how you might avoid them. So it's just that learning from experience business. You learn from all these patients coming in that are having problems, you learn what to prescribe. There is also some science that supports some of these rules. So an important one was a randomized controlled trial by Cumming and colleagues, published in 2007, And the hypothesis was if you give somebody new glasses, they'll be able to see better, and the falling over, will get better. You should fall over less. We know that poor vision causes falls, so fixing vision surely will reduce falls. No. They found the complete opposite. The people who got new glasses, the intervention group, fell more. 758 falls and 31 fractures in the intervention group who got new glasses. Far fewer falls and fractures in those who were left to their usual care. So actually giving old people big changes in glasses makes them fall over more. So we have to be careful. This was the exact opposite of what they expected. They expected fewer falls in the group that got new glasses. They got more falls. Hugely unexpected result. And the vast majority were patients who had high refractive error changes. But by high, it's only 0.75 diopters. That's not big. It's not like Monet's plus 10 with a minus 4 SIL. It's 0.75 sphere, 0.75 SIL. That's all that it took. Anybody who got more than that fell. So big changes, don't give them to older people. Doesn't work. So we've got some prescribing rules. What are they? These are rules that you can use to avoid rechecks. And the most common prescribing rule is if it ain't broke, don't fix it. If the patient has glasses that they like, they have no symptoms, they've got good visual acuity, why would you change it? Based on a subjective refraction? I don't think so. If they're happy, good VA, why change? All you can do by changing them is risk making them unhappy. So we've looked at various sets of data, and 25 to 33% of rechecks, so a quarter to a third, could be avoided with this one rule. If it ain't broke, don't fix it. If the patient has no symptoms, good VA, don't change the correction. So here's an example from a recheck study we did in the UK, published in 2022. And we just collected data from patients coming in who were unhappy with their glasses. So we've got a 74-year-old here, had no symptoms, just wanted new glasses. Look at the change in correction. You've got an 050 with a little bit less minus or more plus, so an 062 change in the right eye there. Why would you add 0.62 to somebody with no symptoms? It's leading to a recheck. And they had distance vision blur, especially in the right eye. Well, that's not a surprise. So at the recheck, they basically returned it to what they had at the beginning, and the patient was happy. If it ain't broke, don't fix it. Another guideline is, if it ain't broke, don't fix it much. So what you could have here is the patient has a real RX change, but currently no symptoms. So there's some loss of VA. They could soon become symptomatic. So you need to be a little bit careful. If the VA is down a bit and you can improve it, you might want to change it, but you might just want to change it a little bit. So just don't fix it much, change it a little. So this is a guideline for young myopes who they've got their first myopic prescription, they become more and more myopic, and then they plateau. And then the correction goes down. So once you've reached the plateau of myopia, it will get less myopic as you get a hyperopic shift with age. Everybody gets a hyperopic shift as we get older. So your myopia, my myopia, everybody's myopia will get less as we get older due to the refractive index gradient of the lens. Remember that myopes are used to slightly accommodating in the specs to obtain very clear distance vision. And remember also that refraction is typically determined at 6 meters, which actually gives you an 0.17D blur. It's not in the far distance. And it is particularly an issue given that we, quite correctly, refract by pushing the plus, maximum plus for maximum VA technique. So it is open to, it can lead to a problem. So we need to be aware of this. So here's a patient, 18 years, again, no symptoms, wanting new frames. If it ain't broke, don't fix it. Patient had -1 0.25, 0.75 with a bit of SIL, and they reduced it here by 0.50. No symptoms, 18. Really? No. So they came back with distance vision blur, and again they were returned to pretty much, a little tweak by 5 degrees there, but pretty much what they had at the beginning, because they came in, they had no symptoms, and they had good VA. So why change? If you wanted to, what you could do if there was visual acuity improvement is just change it a little. Change it by 0.25. If the change from glasses to subjective is 0.50, there are no symptoms, but the VA improves, change by 0.25. Just change it a little. Don't change it the full amount. Another one that's, again, it's if it ain't broke, don't fix it, but this is distance specific. So typically this is when the patient does not have symptoms for distance, but does have for near. Don't change the distance RX in this case. Change the near ad. It's just the same. It's the same rule. And typically, increase the ad by plus or 50 is common. So here we've got a 71-year-old, near vision blur, but the distance is okay. But what they've done is that, again, you typically get a hyperopic shift with age. So this is not uncommon to get a plus shift. But the distance is okay. So that's not a good move. And they got distance vision blur. So again, at the recheck, they still gave them 0.50 more and a bit more SIL, and they wanted another recheck. So this patient, 2 rechecks, 2 pairs of glasses to get it right. Look at the symptoms. Distance vision is okay. Don't change it by 0.75. It's too much. Distance is fine. They've got near vision blur. Change the ad. That will have made them happy. So listen to the symptoms. Okay, as I said, the importance of using the correct working distance is clear with reading ads, and most problems with near specs are due to not fully determining the patient's required tasks and working distances. So let's be careful with the working distances. And again, with older people, it's been found in all the textbooks. So this is from experience. Clinicians have found you don't want to be making big refractive changes. But remember, the randomized controlled trial showed that if you did prescribe big changes, your patient is more likely to fall. So there's double evidence for this. In older people, make small changes. You will get changes that are big in patients with cataracts. Just be careful when be careful. Obviously, you've got to consider driving standards, but try and limit the changes in refractive correction with older people. And avoid oblique sills. Oblique sills are shockers. They make floors and doors slope, they distort objects. Oblique astigmatism changes can lead to dizziness. Yes, so oblique astigmatism is the one to be careful with. With the rule, against the rule, no bother really. Oblique, be very careful if it swings oblique. We found, I think it was 38% of sill changes that were a problem, were oblique. It's the big problem with astigmatism and cylinders. So here we had a 63-year-old in progressives, no symptoms. The change was actually not much. They removed a small sill, and they changed a small sill from 025 to 050 and swung it 15 degrees. Patient complained of distance vision blur and dizziness. So they pretty much, yes, they did exactly. They changed it exactly back, added a little bit on the ad, and that was fine. But see how small that is. You wouldn't have thought that level of sill would cause a problem. It usually doesn't, but it can if it's oblique. If it's oblique, be very careful. Oblique sills are trouble. So in summary, we've got a worldwide recheck rate about 2.2%, and that is the minimum. Lots of patients have problems with their glasses, but do not come back to their optometrist to complain about them. So it's bigger than that. But even 2% means there's a huge number coming back. Try to link symptoms and VA, visual acuity changes, to refractive error changes. Do they make sense? If there are no symptoms and visual acuity is good, don't change it. Don't change the refractive correction. If it ain't broke, don't fix it. If there are no symptoms but VA is down slightly, change it, but only a little. Just change it halfway. Don't change it fully. Measure near working distances, particularly in the over 60s. That is critical because that's what the ad is dependent on. And use prescribing rules, especially in older patients. If it ain't broke, don't fix it. And its variants. Make small changes in older people, less than 0.75 diopters, and avoid oblique sill changes if you possibly can. Thank you very much. Cheers.